Hello, my name is Byung Soh. I will talk about the introduction of Severance Robotic and Minimally Invasive Center. I am the director of Severance Robot and Minimally Invasive Center, Severance Hospital, Yonsei University. Today, my talk will cover brief overview of robotic surgery at Yonsei Severance Hospital. And then I'll review our current result of robotic colorectal cancer surgery. And then I'll also provide you some of the brief updates of recent brand new robotic system, SP robotic GYN cancer surgery and thyroid robotic surgery. So I will start from the overview of the robotic surgery at Yonsei. If you ask me to summarize what is the current status, what is the history of the robotic surgery at Yonsei, I would summarize it in one sentence. We have been the first and the best in the robotic surgery in Korea. We performed the first robotic surgery in Korea back in 2005, and we established the first robotic training center in Korea. Actually, I'm in the training center of robotic surgery in our hospital. Behind me, you can see our robotic system for training. And we have the best robotic surgical team, and we are also the best institution of robotic surgery. We have world's #1 case volume in robotic surgical procedures. So we started robotic surgery back in 2005. You can see the photos of the first generation of robotic surgeons. When we performed the first robotic surgery in Korea, actually a nationwide broadcasting company came into our OR and they made the news in their evening news show program. So this is the installation status of the robotic surgical system in Korea. Actually, it's outdated. It's 2 years ago. Probably 2 or 3 more case systems were installed since. But approximately, we have more than 60 systems installed in the Seoul metropolitan area. And the rest of the Korea have around 25 systems installed. Among them, our hospital has 8 robotic surgical systems installed. 2 of them are recent brand new SP robotic system, and 3 of them are XI, the 4th generation robotic system. And we also have 3 older systems. So Yonsei Severance Hospital has 2 main buildings. The one is the main hospital building. There we have operation suite we call main operation room, MOR. And we also have a cancer center building, separate building. And there we have a separate operation room. We call it COR, Cancer Center OR. So in each operation room, we have robotic systems installed. In MOR, we have 5 robotic systems installed. There, our robotic urology surgeons and ENT, hepatobiliary, and pediatric, and the other surgeons are performing robotic surgery. We have more than 37 dedicated robotic surgeons and nurses. In Cancer Center Hospital, we have 3 systems installed. There we have endocrine cancer surgery, upper GI and lower GI cancer surgery, breast, gynecology surgery, and so on. There we also have more than 30 robotic surgeons as well as 12 dedicated robotic nurses. So this is the annual case number of robotic cases in Severance Hospital. Last year, you can see the numbers are numbers are constantly increasing year by year. Last year, we have exceeded more than 3,000 cases per year. This year, until July, we have exceeded 20 cases. You also know, this year we have a COVID-19 problem, so we may expect some of the decrease in case volume, but still we are performing more than 2,000 cases until July. And the cumulative number of robotic surgery in Severance Hospital is amazing. 2 years ago, we have exceeded 20,000 robotic cases. That was the world record. We were the first institution worldwide where more than 20,000 robotic cases were performed. And last year, until this July, we have performed 27,000 robotic cases so far. And we are expecting probably next year, the cumulative number may exceed 30,000 cases, which will be also a world record. So Severance maintains #1 in robotic surgery. We were the first. We performed the first robotic surgery in Korea. We have world's biggest number of the robotic cases. It explains more than 12% of total number of the robotic surgery in Korea. And we were the first institution to record 1,000 cases using a brand new robotic system, Da Vinci SP. It explains more than 40% of Korea's total case. We also have largest number of the Da Vinci system in Korea. We have more than 68 experienced robotic surgeons, and we have published over 350 articles in a peer-reviewed journal. Actually, Severance Robot Surgery Training Center is located in Avison Biomedical Research Center. The history of the training center actually goes up to 2008, but recently we have moved the place to the brand new Biomedical Research Center. Here we have best training and research environment. We have a 6 operation table in 4 operation room, and we have large facilities that are very similar to real operation room environment. So let me go on with the review of the results of the robotic colorectal cancer surgery at Yonsei. I'm also a colorectal surgeon here, and I'm going to share with you about the lessons we have learned from 15 years experience of a robotic colorectal cancer surgery. So our first Da Vinci lower entry resection at Yonsei was performed in 2006 November. Actually, at that time, it was a hybrid technique, meaning we performed some part of the surgery with the laparoscopic instrument, and then rest of the surgery was done with the robotic system. At that time, the system was standard, the prototype of the robotic system. And since then, now we have 6 colorectal surgeons doing robotic colorectal cancer surgery, and we have performed more than 1,500 cases. And we actually were the pioneers in propagating the robotic colorectal cancer surgery. We established our own method to perform the robotic colorectal cancer surgery, and we published them in a peer-reviewed journal. And then we also developed the standard procedure of doing a robotic lower entry resection. And recently, we also published a new method to perform robotic colectomy using suprapubic inline port placement. So the history of procedure development, we've been with the whole system. The first generation, we used the hybrid system, and with the second and third generation, we developed our own fully robotic technique. and we trained those techniques to global surgeons. And now we have a brand new 4th generation XI system, and we also developed a newer system that fits to the brand new 4th generation XI system. So the case volume by year in our colorectal division, you can see most of our colorectal cancer surgery is done by laparoscopic instrument, laparoscopically, and the robotic surgery actually explains between 15 and 20% of the total colorectal cancer surgery. But I would say numbers is continuously increasing, although it is not very dramatic. So the proportion of the type of the surgery, you can see the back in 2005, open surgery was the most frequently performed procedure, but now it is laparoscopic surgery, and robotic surgery explains around 10%, 10 to 15 to 20%. So colon cancer, we've done around 99,000 cases, also mostly performed by laparoscopic surgery. In colon cancer, robotic surgery proportion is very small. That's because the benefit of the robotic surgery in colon cancer is still controversial when compared with the robotic rectal cancer surgery. So that's why if you see the proportion of the type of the surgery in colon cancer, robotic surgery explains around 2 or 3%. But in rectal cancer, actually it explains around 30% of the total cases. So if you see the proportion of the type of the surgery in rectal cancer, you can see the rectal robotic surgery explains around the 30%. And also laparoscopic surgery is the most frequently performed one. And then nowadays open surgery explains around 10 to 15%. So the case distribution of the robotic surgery, rectal cancer surgery explains more than 85%, and colon cancer only 8.5%. So 15 years of experience of robotic surgery at Yonsei, we have reviewed 1,532 patients in total. As I told you, colon cancer explains around 25%, and rectum explains around the 75%. So you can see the mean age is around 60, and you can see slight male predominance. BMI, fortunately, Korean patient has a lower BMI than yours. But I would say BMI of the Korean patient is rapidly increasing. So nowadays, if we include current patient only, around 5 years, then BMI would be as high as more than 26 or 7. In rectal cancer, more than 40% of the patients have received the neoadjuvant chemoradiation therapy. And in colon cancer, tumor location, more than 75% is left colon, usually sigmoid. And in rectal cancer, more than 80% of the patients has a mid or low-lying rectal cancer. Lymph node yields are very increasing. In colon cancer, it's more than 25. In rectal cancer, it's around 15. Because in rectal cancer, we consider a significant proportion of the patient has received the preoperative chemoradiation therapy, this number of node retrieved is acceptable. Circumferential resection margin positivity is below 4.5%, which is very increasing number. Increasing number. And the you can see the type of the surgical details, surgeries. You see around 20% of the patient have received ultra-low entry resection with coloanal anastomosis, and only 2.9% of the patient received abdominal perineal resection. So nowadays, our sphincter preservation rate is more than 95%. Open conversion, which is very, very low, is way lower than global standard. In robotic surgery, colon cancer, our open conversion rate is below 1.5%. In rectal cancer, it's even lower than 1%, which is very, very encouraging number. And the length of the surgery, the operation time, it explains the skin-to-skin time. It explains around 4 hours in each surgery. Blood loss are acceptable, and the intraoperative complication rate are very acceptable. Short-term operative outcomes, fortunately so far we don't have any 30-day operation-related mortality. And 30 days operation-related morbidity rate is around 20%. Among them, anastomosis leakage rate is about 3.6% in colon cancer and around 6.5% in rectal cancer, which are very acceptable numbers. And the complication, severe complication, more than Klavian-Dindo classification 3A, explains around 8%. And the hospital stay, median hospital stay is 7 days and 8 days, which is longer than results from the Western countries. It's a mainly difference from the medical social system here in Korea, because all the hospital stay is covered by government insurance system. Korean patient doesn't need to pay more if they stay longer. So that's why our hospital stay, median hospital stay is longer than Western countries. Survival rates, overall survival rate in colon cancer is more than 90%. In rectum is 89%. Disease-free survival rate in colon cancer is around 85%. In rectum is around 75%. Survival curves of the colon cancer splitted by stage shows very acceptable results. In early stage, it's more than 90% overall, both overall and disease-free survivals. And in stage 3 colon cancer, overall survival rate is 87% and disease-free survival rate is around 83%. In rectal cancer, also in early stage, overall survival rate exceeds 90% and disease-free survival rate is around 85%. In the stage 3 rectal cancer, overall survival is 87% and disease-free survival is 62.5%, which are very acceptable. Operation time, we analyzed the operation time in CUSUM analysis. Surprisingly, we found the case volume required to overcome the learning curve was higher than previously reported. In colon cancer, it's around 114 cases. In rectal cancer, it was even higher than 300 cases. So take-home messages from our 15 years experience of the robotic colorectal cancer surgery. It is very safe and feasible. But when we look into the learning curves, it is not easy at all. So it is very important to train expert surgeons who can perform the very fluent robotic colorectal cancer surgery. We are also very proud of our training system in robotic surgery. We have proctored many surgeons in worldwide. We've been doing proctorship of the robotic colorectal surgery in everywhere. So let me move on to the current recent updates in Da Vinci SP system. as I mentioned previously, we have exceeded more than 1,000 cases of the Da Vinci SP system. And the system profiles expands actually covers variety of specialty. But today I will specifically cover GYN and the thyroid SP system surgery. For GYN cancer surgery, we have superstar GYN robotic surgeon, Professor Sang-Hoon Kim. And thyroid cancer surgery, we also have another super expert robot thyroid cancer surgeon who is Professor Ki-hyun Nam. And I have, thankfully, they provided their own data for this presentation. So Da Vinci SP system is a brand new robotic system which is dedicated for single port surgery. So different from current robotic system where there are 4 robotic arms, Da Vinci SP system has only 1 arm. But in one robotic arm, it actually has a smaller 4 robotic arm incorporated in robotic 1 arm system. So you can perform very fluent single port surgery. So what's the trend of the SP procedure in Korea? Actually, most of the SP procedure is done by head and neck surgery for transoral SP single port robotic surgery, and then followed by gynecologic single port robotic surgery, and then general surgery usually is a thyroid and cholecystectomy. So GYN robotic surgery at Yonsei, still the majority of the number is XI system, but recently in this year the proportion of the SP system have reached near half of the total robotic surgical system. So gynecologic operation cases by single port Da Vinci SP robot, benign cases 95 cases and cancer 22 cases. So endometrial cancer staging surgery, which is very challenging and very extensive surgery, can be done by Da Vinci SP single port system. So in operation theater, it looks like this. Robotic arm inserted through single small incision at the umbilicus through the dedicated port system. So after the surgery, you can see the scar is really minimal. So this is the immediate post-op scar photo. So after a few months, scar actually disappears away. So patients are very happy. This is the case of the first Da Vinci SP endometrial cancer surgery 2 years ago. So you can see the specimen is very intact and the operation scar is amazing. So when we compare this Da Vinci SP scar with the current conventional laparoscopic single port surgery, the scar size are almost the same. And actually it is hidden by umbilicus. As I mentioned, a few months later, you cannot see any scar at all. So patients are very happy because GYN patients are females and they are very happy with their cosmetic results as well as good oncologic results. And also we have done more than 10,000 cases of a robotic transaxillary thyroidectomy so far. But recently, our thyroid surgeon, Professor Ki-hyun Nam, have started a robotic single port transaxillary thyroidectomy. So the current standard of the robotic transaxillary thyroidectomy looks like this. You make a single big incision at the axillar, and through there you insert 3 robotic arms. and which are very bulky. So because the scar is located at transaxillary area, axillary area, it is hidden, but actually skull length is quite long. So during the robotic transaxillary thyroidectomy, you make a 3.5 centimeter incision long and make a flap all through the axilla to the neck to reach the thyroid. So in real operation theater, it looks like this. They use specialized robotic retractor so that the retractor lift up the skin flap. So in the operation field, it looks like this. You can see the Da Vinci SP robotic arms fluently dissect the tissues around the thyroid gland. So the recent clinical result of the after transaxillary single port robotic thyroidectomy, patients are very young. The mean age of the patients are 35. Of course, almost all of them are female. And mostly is thyroid papillary cancer. And their BMI, because those are young women, BMI is around 21. Preoperative hospital stay is only 3 days. So tumor size is around 1 centimeter, usually micropapillary carcinoma. And the complication rate is amazing. We don't have any recurrent laryngeal nerve injury, and we only have a transient hypoparathyroidism, which are fully recoverable after a few days. And the postoperative pain score is amazing. After 2 days of the surgery, patient actually complains no significant OP pain at all. So conventional robotic surgery, the photo is on your right. You can see the bulky robotic arms are inserted through a long single transaxillary incision. But in single port SP robotic surgery, you have a very small axillary incision, and operation field is not very crowded because we only have a single robotic arm. And the operation scar is amazing. After this is a postoperative scar after robotic thyroid cancer surgery, because they make a small incision through the skin crease in axillary area. After a few months, you cannot really recognize any visible scar in their axilla. So benefits of the SP single port transaxillary robotic surgery start. It's technically very feasible because conventional thyroid robotic surgery, there are 4 robotic arms and all those arms are fighting each other. But in single port robotic surgery, there's only 1 robotic arm, there's no fighting anymore, and very comfortable console handling, and operation time is very competitive, only around 1 hour, and the operation results are very satisfying. For the patient, cosmetic outcome is maximized, and postoperative pain and early recovery due to the smaller wound is guaranteed. So thank you so much for your attention, and I hope you enjoyed my presentation, and if you have any questions or comments, please contact me. Thank you.